right?
Right.
So there's an elephant in the room, right? And so Dr. Keith mentioned Cialis, and I love when I get stuff from the drug reps. So I happen to get this from one of the drug reps. And yes, part of what we'll talk about are some of the comorbidities, even, yes, and you do have it. Yeah, so some of the comorbidities that affect people that have diabetes is erectile dysfunction. And I think sometimes that's one of the first ways we even know that a person might have cardiovascular disease because of that one, that issue that they got going on. So I did not put together the best slide presentation, but I did what I could for tonight for you all. So again, this is a little elephant in the room. And here we go, yes. Awesome sauce. Once you get your hand sanitizer, and you'll see my name on there. I am nurse practitioner Pattye Anderson. And I'm going to talk about Glucagon-like peptides. Class is in session, right? So I will also pass these around. Inside here, you will see some glucagon-like peptides, right? I'll start right here. And then here's some tiny little pins, needles that patients use in case you've never seen some of this stuff. So maybe you can aim that a little bit over at me. Yeah, that'd be fine. Or maybe, let's see.
I love your desk.
right. So, let me try to do this correctly. So yes, glucagon-like peptides. I am Pattye Anderson, and I'm so glad to be able to do this presentation a second time and see all you faces that some of you I've recognized for many years. And I'm so thankful that Dr. Jordan, Dr. Pyle, Dr. Jefferson, and my mentors invited me so many years ago before right when I was beginning my career in healthcare. So who am I? So I am a nurse practitioner. I am board certified, double board certified, I like to say, in family and HIV medicine. I got my bachelor's in '94 from USC, go Trojans. I got my master's in 2004. Did I say 93?
Okay,
so in 2004, I got my master's from UCLA. It had not been for USC, I owe a lot to USC because had it not been for them, I wouldn't have my career. So some people ask me, like, which do you have most alliance to? Well, I have my most alliance to USC. Right? Yes. And I'm currently working on my doctoral degree in public health epidemiology. Some people say, well, what's that mean? It means that I'm going to be a Dr. Fauci one day. People understand what that kind of means. Thank you. I'm not far from it, so I'll keep you posted. I do have a black belt in Taekwondo, so I'll protect most of the people here in the room. And I am a Spanish bilingual concierge consultant, so that's kind of what that little pin is about. I have my website on the screen here. So one of the things I really like I have chow chow dogs, but if you were to say, like, what's your favorite animal? Well, one of my favorite animals is actually the elephant, right? And one of the reasons why is because they kind of don't forget things, and they're strong, and they have this image of having, like, they're afraid of peanuts, or they like peanuts, but what are they afraid of? They're afraid of mice or something, right? So there's a lot about elephants that I just like, so I was glad to be able to bring my elephant to show it to you all. But one of the things I thought about as I was putting this together was acronyms, right? And so you might have heard of GLPs. So what does a GLP mean, right? So a GLP is like an acronym, like Dumbo is an acronym. Who likes to travel? Anybody? Show of hands. Right? You guys have time to travel. Good. I don't. I don't. What, has anyone been to New York?
On.
Right? Are you familiar with this bridge? And did you know that there's a bridge called Dumbo and an area called Dumbo? Right? I did not until putting this together. So Dumbo means down under the Manhattan Bridge overpass, and it's a very popular tourist attraction location. But also, like I said, GLPs, GLP is another acronym, and it stands for Glucagon-like peptides. Has anyone heard of these glucagon-like peptides? Someone said Ozempic a minute ago, right?
Yes.
Any others that you're hearing about?
Rybelsus.
Rybelsus. What others? Wegovy, I think I heard.
Wegovy.
Right? Mounjaro is another very popular one. And recently the FDA approved one called Zepbound. Ridiculous name, Zepbound. So like Ozempic, Wegovy is the counterpart, kind of sister medication of semaglutide, and Zepbound is the counterpart medication of Mounjaro. So one is for diabetics, the other is for weight loss, right? And the generic name for Mounjaro and Zepbound is tirzepatide. So you might have heard some of those names, and if you haven't, you're going to, because they're not going away. I became very familiar and comfortable prescribing these medications before the pandemic, when I would have some reps come visit me, and they would bring Rybelsus, and all the time, Rybelsus, all of it. And I thought, okay, this is cool. And I started trying it to see, like, how does it work? What happens when you try it? And so what they are, they're amino acid long peptide metabolic hormones, or also called incretins, that they're released after we eat by the K cells, and they help with the release of insulin. And these are also sometimes called, like if you have an AKA, also known as, these are also known as glucose-dependent insulinotropic polypeptides. Big fancy word for GIP. So you're going to see GIP /GLP a lot of times, because some of the newer drugs like Mounjaro are combination drugs. They're not just GLPs. And so why did I even become interested in the context of HIV medicine and GLPs? And I started kind of talking to some pharmacists and some friends, and one reason is because, I made myself a few notes, it's because the A1c in your HIV patients is sometimes skewed falsely lower. And that's scary, right? Because if somebody has diabetes, you kind of want to know it, don't you?
Yes.
Yeah, and if I do an HIV if I do an A1c test on someone that has HIV, I want to know, hey, is this person a diabetic? I need to be treating them. So that's how I kind of got interested in finding out more about this class of medications. And again, the GLPs and the GIPs, they're inactivated by another kind of hormone or product called dipeptidase 4, DPP4s, to stimulate insulin secretion after oral glucose load via the incretin effect. So in a type 2 diabetic, this process becomes blunted by the absence or absent in a person. And so by giving GLPs, we can help revive that insulin secretion and thereby bring that blood sugar down. One of the good things about these GLP medications is that they don't bring the blood sugar down super low. Now, before I go on, I'm going to say I'm not a mind reader. So if you have any questions, you don't have to wait till the end of my presentation. You can raise your hand and throw out your questions. And if I'm going too fast, or if I said something and you're like, no, I heard this was different, I heard, whatever. Go ahead and don't hesitate to let me know, because I'm not a mind reader, right? Okay, I might be, but right now I'm not. So why are these GLPs so useful? And why is everybody trying to get them? Is it because of Kim Kardashian saying that she uses them? right? Is it because everybody's talking about them? Everybody wants to not just control their diabetes, because many patients are not diabetics that want these. Many patients want them for what reason? Do you know?
Weight loss.
Weight loss. Right? So that's one of the major effects of the GLP-1 class of medications. Again, glucagon-like peptide, you might see RA, receptor agonist. It's like a receptor agonist is like saying, I've got a key, I'm going to put it in the keyhole, and that's your receptor agonist. I kind of try to describe it that way, if I'm correct or not. So what they do, they reduce body weight, blood pressure, plasma glucose, and plasma lipids in several different ways and mechanisms. And according to the American Dietetic Association, this is really important and really needed, because we got so many patients that are diabetic. And some of my slides are a little bit out of sync, but I'll get to why we need to be using these medications. So again, these medications will reduce your appetite, and they'll increase your satiety, meaning you'll eat a bite of your food on these medications and you're full already. And that's one of the effects that it has on the brain. I mentioned earlier the effect on insulin and how it increases the reviving that insulin boost in a person that is a diabetic. It reduces liver fat, reduces inflammation, reduces insulin resistance, also increases diuresis and sodium secretion. And you can see also some of the other parts of the slide. It increases myocardial contractility, glucose uptake is reduced, ischemic preconditioning is increased, endothelial function is increased, and arterial stiffness and inflammation are both decreased. And so, again, these are some of the wonderful benefits of using that this class of drug. Some of the names I've already discussed: Ozempic, Rybelsus, and Wegovy. Those are all called semaglutide, and I don't know if the box is still going around, but the pens on these on the injectable versions of these are so tiny that many patients don't mind using an injection. Yes.
Quick question. Back to your previous slide, where it was showing all the pretty much like the pathophysiology of what is going. So is the end result more of a ketosis that's happening as the reason why the body is gonna get into fat burning mode, and is that the end of this pathway?
Well, I'm not an endocrinologist, so I can't say that that's actually the end result. But so there's so many different alternative medications to use, and the ADA has decided that this is one of the best medications to use in controlling diabetes. So I know there's probably some diabetes specialists somewhere in the room, right? Some that can maybe
endocrinologists
and specialists. I'll leave that for them to answer about that ketosis, because I don't. I appreciate it. But as I said, some of the other types, because many people forgot about Trulicity and didn't even know about Saxenda. And so what's the difference? Some of the differences is that you have some that are oral. Not many are oral. We have Rybelsus, which is the only oral semaglutide. It's the only oral semaglutide. There are other oral GLPs and other obviously diabetic agents, but again, this is probably the best class of diabetic glucose lowering agents. Ozempic, Wegovy, and Mounjaro Zepbound, those are all weekly injections, much more doable and less threatening than your daily injections. I don't know a lot of people that like doing daily injections, but some don't mind, because some people, my patients will say, they feel better because they have a more frequent reminder about how to take care of themselves and have a better lifestyle. Okay? And again, you'll see what some of these medications are approved for. Some are approved for diabetes. Can you see this slide okay?
Yeah.
Print not too small? Good. So some of them are approved for diabetes and some of them are approved for weight loss. Now what about the other classes of diabetic agents like the SGLT2s or the sulfonylureas? What about those, or insulin? Anybody think about why use this instead of those?
They got more advertisement.
More advertisement?
And the others don't promote weight loss.
Some don't promote weight loss also. And so the SGLT2s, right? Sodium glucose co-transport inhibitors.
Yay.
Did it. Some of those will promote weight loss as well, but they are indicated for people with different comorbidities, right? So if you have end-stage renal disease or other problems, then this is not the class of drug for you, okay? Also, yes, the SGL, they will also help with a person that has heart failure. And even though they help with weight loss, these are not really indicated for heart failure patients. Now, if a person is interested in one of those other medications, are you going to just tell them to use this because you want them to? Yeah? Okay, so the answer is no. You're not going to just say, oh, you should use this one because I saw the commercial and I know everything. No, you want their buy-in. You want their shared buy-in and opinion, because ultimately they're going to be the one that's going to do the shot or take the pill every day or not. So if you force something on them, like let's say insulin, they're probably not going to want to just use it. And also about the ADA, they have the opinion, and I agree, that your insulin is going to increase body weight and also promote low hypoglycemic states, whereas again, the GLPs do not induce hypoglycemia and they do promote weight loss. And so that's one of the biggest things that we need to keep in mind, that if a person has a BMI that is above normal, then we're trying to get them to a healthier state. So when we define or diagnose a person with diabetes, we want to look at how we're diagnosing it and how we're defining it. And if I go back to that initial mention about A1c and HIV, do you know why the A1c might be lower in a person with HIV? Anyone? Any of our specialists?
I never knew that until now.
I didn't know that, and even we had someone that spoke to us a couple weeks ago, right? I asked him, and he really didn't have a clear answer. And so what I did, my quick study, was I found one study that was conducted in 2009 by a group, and it was a prospective cross-sectional study of about 300 HIV positive and negative patients, and it also concluded that A1c is underestimated or underestimates glycemia in HIV patients. And it is not just because of the MCV, or mean corpuscular value, and even though our MCV is lower in patients that have hemolytic anemia or sickle cell or end-stage renal disease because of a faster blood turnover. But what this study concluded was that medications that we use to treat HIV create a false A1c. One drug class in particular are the NRTIs. Anybody know some NRTIs that you're using? Come on.
Descovy,
Right?
FTC, 3TC.
They're in a lot of our drugs because we're using this 2 drug and 1 combination, right? So many of the HIV drug combinations have these NRTIs, and that was their conclusion. Again, this study only had about 300 patients in it, but it was still significant enough to make you say, should I be using an A1c test to determine if a person has diabetes, right? So there are other tests that we use, like the oral glucose tolerance test, and we can use a fasting blood sugar. And I know you might not quite understand my Latin there, but the oral glucose tolerance test, if you have a result of over 200 after 2 hours, then that qualifies a person as diabetic. If it's 140 to 199, then a person might be called a pre-diabetic. And also, if you have a fasting blood sugar of 126 twice, then that is also considered a diabetic. Now, I found another study. This was conducted, I believe it was in 2013, by another group of doctors, much more robust study, and it was by Malmstrom and Associates, and they looked at the utility of fructosamine for diagnosing diabetics. And it was a cross-sectional and longitudinal study that included 10,000 patients. And they did conclude that the fructosamine test is a better test to use, but it's not recommended by the ADA. So chew on that for a little bit and do with that what you will, right? So again, we're using these GLP-1 drugs for diabetes and for obesity. Who knows how we diagnose obesity and overweight? BMI, right? I was talking to someone the other day, and I said, well, your BMI is probably this. And they were kind of like, well, they know what the BMI was. And then I described someone else. I said, well, their BMI is probably 23. And they said, well, I've never heard anyone describe someone by their BMI. I can't help it. I just, I see height and weight, and my mind just kind of goes to, oh yeah, I remember that person is whatever. So I love this website. I use it a lot because it's kind of my consistent standard. And you can just plug in a person's height and weight, and you hit compute, and boom, you get your BMI. And as you see, the overweight category begins at 25 to 29.9, and a person that's obese has a BMI of 30 or greater. So many people that have type 2 diabetes have a BMI of above 30. Not always, but many times. Any questions on that?
What's morbid obesity?
Morbid obesity is a person whose BMI is even higher. So we're talking 40 and above. Yeah. And so the GLP-1 category of medications, if you're looking at when they're going to be approved, let's say I'm just going to write this medication for someone. It's not always going to be approved because either their insurance doesn't cover obesity drugs or they're not a type 2 diabetic. So if they come to you and they say, I'm a diabetic or I'm a pre-diabetic, well, let me see your A1c. And if they come to you and their A1c is 6.1, they're not going to qualify for it. And they're going to ask you for it. Well, that's okay. You can still write their prescription, but they're not going to get it covered by their insurance most likely, right? Now, there's Amazon that has medicines that's a lot cheaper, just so you know. And then let's say, well, they know they're not a diabetic, but they say, well, I want it because my BMI is above 30. Does every insurance policy cover anti-obesity drugs?
No.
No, not at all.
Right. So then what do, right? So people are really, really desperate, and you have to sometimes tell them that there are other medications that will help them reduce their BMI and reduce their risk of diabetes and stay healthy. So, Jenny, I have a question. Yes. So, if the patient is considered obese, how much weight are they going to actually lose? Right, that's a great question. So many patients can lose, I want to say, I had the number in my hand and it's gone, but patients lose a considerable amount of weight and it doesn't take a long time. So the higher the concentration of the medication in their system, the more they will feel the effect. Thereby they're not going to want to eat and they're going to be just losing the weight. I want to say it's about 22% of their initial weight. If I'm not wrong, don't quote me, but they can lose a considerable amount of weight. And I track that. I've had patients lose well over 100, several patients lose over 100 pounds. Yes, since I've been treating. How long are they on? I've had some patients that were on the medications for 9 months and longer, but still 100 pounds over 9 months is...
Wait, what were they on? You lost 100 pounds?
Ozempic and Mounjaro were the two.
Both?
Yeah, they can't be on both at the same time, but sometimes because of the insurance switching, the patients will also switch. Yeah.
So are you monitoring the A1Cs every 3 or 6 months to keep it being covered? Or you just say as long as the weight loss is coming off and they're getting to
Excellent
the
question.
BMI is your cutoff?
Excellent question.
How do you do that?
So once they have an A1C of above 6.5, they're going to be covered. So it doesn't have to, once it gets, let's say, down to 6.0, they're still going to get covered because it was once at 6.5.
So even if it goes back under
Yes.
what would be considered diabetic,
Right.
it will still be covered?
It will still be covered. Patients don't know that. So that's why I passed out those pens, so those sanitizer pens, so you can tell them that I will help them get their medication. And sometimes it requires a prior authorization, and you have to include some of these caveats that the insurance company is going to sometimes bet that you don't know, right? And not include. Yes.
So is the treatment for a year, 6 months, or
Another-
do you stop it? And if they stop and they increase the weight back, or?
Another
And
great
A1C
question.
goes up?
Another great question. So when I ask a person, when they ask me, how long am I going to be on this medication? I ask them, how long have you been over 170 pounds? Or 190 whatever pounds? How long have you been obese? If it's been 1 year, well, okay, maybe you'll be on the medication for 1 year. But I don't know many people that are suddenly obese. Many people will tell me, I gained all this weight after I had my first child. How old's your first child? 29, okay, or, right, my first child, right, they'll say, I gained all this weight after whatever, after I finished, I started working, and I'm sitting all day, that's when I gained all this weight. So I tell them, you might consider that you're going to be on this medication for a while. Does the weight come right back? Not necessarily, because maybe they have learned some lifestyle modifications to control themselves. But there's this thing called a set point, and it's kind of an area where the body kind of likes to be, right? You might have heard about that. I can't really speak a lot on that topic, but I will say that the A1C can go back up because sometimes people revert back to their habits and they don't feel the effect, because you definitely will feel an effect on the medication. So what does it feel like from someone that's tried it? Has anyone ever tried any of these GLPs? You don't have, has anyone? Okay, I'll raise my hand. Anyone besides me has ever tried one? No. Okay, so what it does, you literally will eat a bite or sometimes a few bites, and your brain and your stomach are full already. And you're like, well, okay, I want to eat the rest of my steaks. I want to eat the rest of my my anything. And your body kind of doesn't let you. And again, it's a dose-dependent effect. So some patients will say, I didn't feel anything on the 2.5 milligram sample that you gave me. And what the drug manufacturer recommends is that they stay on that one dose for at least 4 weeks. before they transfer up to the next dose. When they transfer up to the next dose, not only does it prevent really nasty side effects, but it also kind of gives them a little chance to get used to what it's like to do a daily or weekly injection. It kind of gives them a chance to see what it's going to feel like. So let me jump to this next slide, and I will come back to this one. So as I mentioned, some of the side effects. And don't forget, we got our elephant in the room. And again, if you have any questions, don't forget you can throw them out at me. So some of the side effects, yes, nausea, vomiting, diarrhea, excessive belching, abdominal pain, and that's kind of what a person might feel on these medications. Why might they feel that? Well, if you've ever heard of some of the medications that are for alcoholic, like disulfiram, antabuse, to help stop drinking, you can almost say it has the same kind of effect. So a person says, I'm going to eat my entire burger no matter what. I'm going to eat all my fries because I paid for it. I spent $20 on this burger, right? I went to wherever place. I'm going to eat all of mine, and we don't necessarily have that discipline yet. And guess what happens? You get that side effect. But another thing that happens is it slows down the gastric motility. So anything that you've eaten takes a long time to come on out. So you can imagine you had the burger, you had the fries, you had the shake, and now everything feels like it's sitting right here. And it's ready to spew out because you tried to eat as much as you could. Whereas the drug is doing its job and it's telling your brain, I'm full. It has a satiety effect. It has that effect in the stomach. The stomach says, I'm full.
So with this decreased motility wave movement, where the stuff stays up, are you at greater risk now for getting the more H. pylori or the overgrowth of bacteria or things like that because things are staying in your system longer than they should?
No, person, I kind of, I assume, but I know that H. pylori is kind of one of those germs that a person can pick up. So to prevent H. pylori, I tell people stay away from the food trucks and the areas where they're most likely to pick up, or street foods as much as we like them. I love the smell of grilled onions, but I have already learned my lesson. You go out and you have the oh my gosh, I learned my lesson. And it's not worth the aftermath. Not worth the aftermath. Trust and believe. So that's the thing. It's not that it's going to cause a higher risk of something like H. pylori or whatnot, but you want them to just remember that they should cut back on not only their foods, but cut back on their other blood sugar medications to also prevent hypoglycemia. Another thing that I didn't include in my slides is that the monitoring of these medications, you don't have to do a lot of monitoring, so you don't have to monitor their liver or their A1c. I mean, you can. It's a good idea, but you don't have to because of the pathway that these drugs go through. So they're not renally excreted, they're not hepatically excreted. How are they excreted? I've asked that question to the reps a couple of times. No one's really been able to give me a great answer, or even how low can an A1c go before it's like, oh, is this dangerous? Is the A1c? I saw someone's A1c of 4.7, and I thought that's mighty low. But I guess it's, they're feeling fine. They're walking around doing fine, and everything is copacetic, right? So, so what do we do when a person does say, "Hey, I've got this horrible diarrhea or vomiting"? First of all, you tell them that they really need to stay very, very well hydrated, and you can offer them things like ondansetron or Zofran for the nausea, but you don't also tell them you cannot eat your entire burger. So just start ordering the half size or the kid size. Tell them just order that, save your money, share your meals, and know that if you don't, you're going to have side effects. Okay, but plenty of water so that they don't get like an acute kidney kind of dehydration sort of thing.
Pattye.
Uh-huh.
I don't know if you're gonna get to, but is Rybelsus and Ozempic equally effective in losing weight?
Yes, great question. So the studies have shown that the daily oral Rybelsus and Ozempic, which are the same exact medication, semaglutide, they are both equally effective for weight loss. But again, you have to go up on the dose. So many of the reps will give you a 3 milligram dose, 30 tablets. They take it on an empty stomach about 30 minutes before any other medication with a small sip of water. And then after a month, they go up to the next dose, which is 7. For some people, that's all they can tolerate, because they might feel like, okay, I went up to 14 milligrams and I suddenly got all the belching and stuff. I didn't like that 7 milligrams. So they can stay on 7 milligrams, but it's daily, just like I said, 30 minutes before anything else with a small sip of water. Or micro injection, and if you saw the little needles going around somewhere, it's a tiny, tiny little needle. Some people can barely even see the needle, let alone feel the needle, right? It's around somewhere.
Is the cost the same?
No. So the cost of Rybelsus is the cheapest, right? And the cost of Wegovy, which is for weight loss, is probably one of the more expensive ones. Saxenda, which is a daily version, is one of the most expensive. Whereas Mounjaro and Ozempic, they're about side by side. And we're talking about 1,100, not about 1,000 to 1,100 per month for Mounjaro and Ozempic. Whereas, and you can go on websites like GoodRx.com, type in your favorite pharmacy, type in the medication that you're looking for, and it spits out the cost. Very easy to do. And then again, like I said, there's Amazon.
So are the sub-Q injections versus the daily dose of the pills, are there any studies to show, are they pretty much the same in terms of the outcome? Or are we seeing an increase, weight loss with the sub-Q injections versus the pills?
From what I've read and heard and talked to the reps about, the results are the same.
Prescribe the pens.
Well, so you have people that are very, very averse to doing anything daily. It's just like with your HIV medicines. I can't take a pill every day. I forget to take it every day. I can't swallow. I gag when I swallow. They come up with every reason, right? So I work in Skid Row right now. My patients get their medicine stolen all the time. You don't want to get $900 worth of tablets stolen.
People on Skid Row want to lose weight?
Oh yes.
Medi-Cal pays for it.
Medi-Cal pays for
It's eating is the problem with them. Eating every day, 3 meals a day.
No, it's not, because guess what? You have places like, I won't say which mission, which Fred, whatever mission, but they get a whole plate of potatoes and a bottle of soda, and that's their meal.
So you seeing obesity on Skid Row?
I see obesity on Skid Row, lots of it.
Yeah, because guess what? A lot of the, so now in the men's community, a lot of the hamburger stands and all the stuff that you probably shouldn't be eating, they take EBT now.
Yeah.
No, they do.
Yeah.
So you just go in and you swipe in your EBT card and you get your chips and 2-liter sodas.
And I even have patients say that they want healthier food in the shelters and the free food. They want healthier food, but that's not what they're being offered. So yeah, obesity is a problem even in the homeless or unhoused group of patients. So I did put some references here. I will make these available to you. If you want, you can either contact me directly, and I should have put my email address on there, but my email address is Nurse Pattye, and Pattye has an E at the end, so Pattye, nursepattye@gmail.com, or you can just visit my website, and I'm very, very easy to locate. And one reason why I'm easy to locate is because I do crazy stuff all the time. Now, I've been saying all along, I'm not a mind reader, but I might be a little bit of a mind reader. I'm just throwing
Is that
that
a
out.
rogue Pattye?
This is the old Pattye. This is before Pattye stopped taking all those GLPs and put some weight back on. And I broke my foot. So, but they say you finish on a high note. And so what I wanted to do is try to show you how to finish on a high note. And one of the things I like to do is
Can you do that?
impress folks with all my skills.
Whoa.
Oh my God.
You go, girl.
Okay.
Yeah.
Okay.
Now, while you're watching this, just to prove that I might be a mind reader, I want everybody in the room to think of a number
7.
and keep it in your head. Don't without saying your number out loud. Keep your number in your head. You can write it down. Think of a number between 1 and 8.
Okay.
Then I want you to multiply that number by 9. Keep it in your head. Multiply that number by 9. I want you to add those two numbers together.
Whoa.
I know. I'll slow down.
Okay, what was the first one?
You're going to take a number between 1 and 8.
And multiply it.
By 9.
Now multiply that number by
And
9.
then add that.
Keep it together. Keep it quiet. Now, after you've multiplied that number by 9, I want you to add those two numbers that you came up with. Add those two numbers together. Good. Now keep it in your mind. I want you to subtract 5 from that number. I know it's getting complicated. Bear with me. I'm a mind reader. I know what you're going to come up with. I promise you. I already know. You can see it. Right? So you subtracted 5 from the number that you came up with when you added them together. Now there's a number that you have remaining. Think of a country that corresponds with the number that you came up with. So if you came up with a 2, think of a country that begins with a B.
Huh?
What?
Right?
So the letter.
You got it? So if you came up with a E, if you came up with a 5, E is the letter that you're going to come up with. And I want you to think of a country that begins with that letter. Now I want you to take the second letter of that word, that country. Now think of an animal that corresponds to that second letter. And what is that animal?
Koala bear.
Okay, all right.
Elephant.
I see it.
Okay, you guys, you're all scientific people. Come on. You got it, right? So I learned that from someone else. It was my little parlor
I
trick.
couldn't pay attention.
Yeah, you have to pay attention. You have to pay close attention.
I'm just old.
But anyway, that's my presentation. Does anybody else have any? Congratulations on getting to the top of that rope. That was a feat in itself.
What did you think?
No, I had to
I started learning how to climb the rope for the Spartan event.